Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
we are going to be discussing the management of the axilla. No doubt what to do with the axilla.
I recently went to my first, I was very impressed with myself for breaking a board.
Little known fact, we were child models in Japan. Management of the axilla, Z11.
But now the whole thing gets blown up a little bit.
Who are the people that we 100% need to still look at the lymph nodes in and do either?
But you know what subset of patients just still really scare me?
Is our goal to all be on the same page as to de-escalation of care.
We may be trying to treat a tumor board much more than we really are thoughtfully treating that patient.
How would that accrual work for no management to the axilla? Do any of you guys have protocols for who you're avoiding a sentinel lymph node on, or is it a case-by-case basis?
If they're not going to take their systemic therapy, if they're not going to do their radiation, and they don't get a lymph node, what happens to them?
This is Carla,
Ellie,
Michael,
Susie,
Sitcha,
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care
to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing. Hey listeners, you are in for an amazing podcast. We are going to be discussing the management of the axilla. No doubt what to do with the axilla. On one of our earlier podcasts, we discussed what made us excited about being a breast surgeon. And one of the common themes was the growth and the progression of care and how it can be complex and how we combine it with our technical skills. But before we get into today's topic, let's hear some personal updates. Ellie, let's start with you.
I recently went to my first Tony Robbins event. I don't know if anyone's ever heard of him or been to anything that he's done, but he's a certified strategist and helps people kind of get clear on their business. And my husband is trying to figure out a career change. So I figured I'd support him and go to this too. And I broke a board in half during this. He usually does fire walks. We didn't do that this time because it was virtual. Spent 4 days doing all this personal to professional development stuff and learned a lot of cool strategies that a lot of the other parts of the business world use in their leadership. So it was really interesting to learn about because I know a lot of business people and CEOs do this kind of stuff, but medicine doesn't always expose you to this. But it was really cool to see how everyone else kind of keeps up leveling themselves and the tools that they use. So that was a very interesting event. Again, I was very impressed with myself for breaking a board. Another fun thing I did, I went to puppy yoga. Basically, we got to do yoga and puppies ran around us. I'm now signing up for goat yoga. That's next. But it was wonderful. I can't recommend it enough. If you have puppy yoga in your city, go for it. It was just a delight.
Ellie, it sounds like you have a lot of time on your hands. I'm trying to figure out what I'm doing wrong, and you have time for all these things.
Yeah, no, I learn in these things how to manage time really excellently. So I control my time quite a bit. Michael, what about you? How is your cow? What are the updates?
I signed up for cow yoga
and they're walking around you.
And that went poorly. Physical therapy is now starting next week, and that's not been well. My cow came and saw me, and I was out there, and then this time she came up to see me. She's looking bigger. There's calves like popping up everywhere out there. Mine's not having it yet. What's this gestation period you guys said? Like
9 months.
I'm not sure we were even pregnant, but she doesn't hate me.
Maybe she's
That's
just
good.
eating a lot.
And so I don't know what she's doing, but the cow yoga thing doesn't work. I will advise against, and I will keep the cow update going, waiting for number 23 to have a cow. That's how I identify my cow. She hasn't.
Michael, you've got to name your cow. You got to name the mother. Maybe she doesn't have enough love from you in order to produce.
I bought it and already had the ear tag. So did Michael Jordan wear number 23?
Jordan was number 3.
We'll call this cow Jordan, but I don't know what the baby's going to be. Baby Jordan or little Jordan or something. I don't know.
As long as you don't call her Michael.
That's good. Somebody ought to name this cow. Somebody in this group.
We're getting there.
What?
We're getting there.
Okay.
It's a surprise for you.
Okay. All right. Sitcha, any animal yoga coming your way?
No, Michael, but I heard that the best way to be successful with cow yoga is to do it with the cow. Like, it should be like a mommy and me class. Like, you should be down there with the cow doing the yoga, and that's how you make it work.
I've watched these videos on birthing cows. I don't want any part of this, actually. I didn't do well with birthing humans. So birthing a cow is just, I'll send flowers or something.
I want to help with coming up with a name. I'm excited about that. Updates at work. We just finished up a few rounds of surgical oncology fellowship interviews and breast interviews. I love interview season. It's exhausting and it's taxing and it's a day away from clinical activities. But just to meet some of these absolutely brilliant minds in our field who, like Ellie, have a lot of time because they're so accomplished, so well-rounded, and interview so well. And it's fun meeting everybody. And I love that everybody out there seems to be listening to our podcast. I just love that. I've been hearing a lot about it on the interview trail from people.
Do you really think they're listening?
Yeah, bonus points if you mention it.
Exactly. Are they like, it's like they look up your CV, see, let me mention this article that I read that they wrote. Now it's, I know she's doing a podcast with ASBRS. Let me mention it, because I had that also.
Yeah, no, I start quizzing them about it after that, so.
I did not.
No, and the other thing that keeps coming up, like just amongst colleagues, and just goes to the relevance, I think, of the topics. It's exciting to talk about these topics. It's relevant. It's coming up in so many conversations.
I don't remember, but
podcasts,
like long after it's been aired, there's still conversation about it, and we can still think about it and take home little points. I think that is so neat. Okay, Susan, last time you talked about all your deadlines. Tell us something else fun about you.
Well, I think that the announcement today, and, we might even need a drum roll. I think that on our Facebook group, the Next Breast Thing podcast group, that we will have a baby naming contest for number 23's baby. Maybe we should have a mommy naming contest and a baby naming contest. But Michael, if the cow's not pregnant, what are we naming?
We'll name the female, and then if there's a baby, then we can have a second contest.
So we'll first name number 23. How about that?
That's
okay. Go to our Facebook group and let's start the naming contest.
I'm going to get a collar with its name on there.
I think we need a picture too.
Oh, Michael, that's
all right.
Susie, that's awesome. So let's put a picture of number 23 up.
Okay.
And figure out a name. There you go.
We need a catchy name for this contest.
It'll come up. Carla, tell us about the lake house, the commute, or what else is new with you?
Yeah, the commute, I'm just counting down the days until I don't have to commute 2 hours every day. So unfortunately, everybody who works with me and you guys and everyone listening has to hear about it all the time. So I'm trying not to talk about my commute all the time, but I am talking about it a lot.
You do get used to it.
Well, I am not there yet, but I am really excited because I'm getting ready to go on vacation. I'm going to Japan. And my brother and I lived there when we were younger. Little known fact, we were child models in Japan.
my med school friends make fun of me about because that always came up. Oh, I was a model in Japan. We lived in Japan back in the 80s, and we are going back with my husband, and then my brother and his wife and 3 kids are all going. We lived in Kobe, Japan. I didn't eat Kobe beef at the time, but we're going to go to a steakhouse and do that and see the apartment where we lived. We're going to go see the school we went to. I've sort of looked all that stuff up. And so it's just going to be really special for us to do that together, and then also with his kids there. So I'm really excited.
So cool.
That's amazing. For those of you who have not been able to do a bucket list trip, Japan is an amazing place. We went last year, and it was really special. So let's move on to our topic, no doubt, what to do with the axilla. Navigating axillary management can feel like venturing into uncertain territory. And in this episode, we're going to talk about management of the axilla, how much has changed over the past 10 years, where we might be headed. We're going to talk maybe about our own approaches and practices, and how do we become confident about managing the axilla? This is really complex. With the management of the axilla in the 80s, there was a standard way, and then all of a sudden, 2000s, 2010s to current, this is just really changing. I graduated fellowship in 2011. That was when the ACOSOG Z11 trial was published. Z11. One of my talks that I do, I actually just gave it to the Cancer Center a few weeks ago. I have a talk called Total Axillary De-escalation. I always say when I was a resident, we would do the sentinel node first. That would go to the frozen room. We'd do the partial mastectomy. We'd wait. Okay, we're going to do an axe dissection, and then we'd go back and do that. And then obviously I was a breast fellow, and I was doing breast procedures. And my first year in practice, obviously the abstract had come out already. But this paper comes out saying, hey, look, in patients having breast-conserving therapy who have 1 to 2 positive nodes, you don't necessarily need to do an axillary dissection. And Ellie has talked about sort of being a new attending and a little bit more conservative when you're starting, you're really going by the book. And it just threw me for a loop, because half the patients we were discussing at Tumor Board were, does this patient meet Z11 criteria? Do I need to do an axillary dissection? And it was very controversial at the time. There may still be some critics. No clinical trial is carried out perfectly, but so many things have happened since then. I think in modern breast surgery history, that's kind of the start of the pivotal trials. That's my argument.
If we're going to talk clinical trials, and I don't quote trials very well, but CALBG 9343 may be my
It is his favorite.
It is my favorite.
He works it into every conversation possible. Well, like, oh, what's your favorite type of food? Well, CAL. Can I get you a drink?
It's the only trial I actually know. But what it did do is it allowed us not to sample nodes. That's where I think I would love to see us go. We may or may not get there, but that was the first time where we began to realize that there are patients that we don't need to check nodes on. So omission is my favorite part of the axilla, to be quite honest with you. I know we can't do that yet on everybody. Maybe we will. But if we're going to be quoting trials, and that is the only one I know, so it's a very timely trial that I can quote.
So let's do a clear-cut thing. Who do you feel comfortable omitting looking in the axilla for?
Well, I mean, it depends on the scenario. In that scenario, it was basically luminal breast cancers. They tried to hedge towards luminal A's. It was patients over 70, small tumor size, clinically negative nodes. And then we moved to prime 2, which was 65 and older, but they sampled those nodes. But now the whole thing gets blown up a little bit with the sound trial. It really kind of depends on what you're looking at. And then you ask yourself, well, okay, if we're just going to omit it entirely, is there a subset of people, I'm anxious to hear from you guys, are there a subset of patients that even though you look at their axilla sonographically, that there is still benefit in sampling the nodes for how they're treated or opportunities for neoadjuvant therapies? And we've kind of touched on this previously on a prior podcast, but in this day and age, we cannot totally omit them, but we're heading there pretty fast.
I think that's a great question on there. So who are the people that we 100% need to still look at the lymph nodes in and do either some type of dissection? I think if we get both ends of the spectrum kind of defined, These are people we can omit. You'll probably never get to find that.
Yeah, I think it's going to be hard to get 100%.
100% is tough. I tell people all the time, there's no 100 and there's no 0 in what we do.
My inflammatory breast cancer patients are almost always going to get an axillary dissection. I just did one the other day, and there's a certain subset of patients who present with really advanced axillary disease, and it's still very obvious even after a neoadjuvant systemic therapy approach. And they'll get an axillary dissection. I think there's a growing use of targeted axillary dissections, however you define that, whether it's just the previously positive clipped node versus the clipped node and the sentinel lymph node biopsy. And I think there's a lot of emerging evidence for that. I'm hoping one day that'll replace all axillary dissections. But you know what subset of patients just still really scare me? The invasive lobular carcinomas. That's where I just always get fooled. I always think a preoperative radiologically no negative, clinically no negative. I'm not worried about it. And then I get 14 positive nodes and always find myself scratching my head with these patients.
All right, devil's advocate time. So you're going to what? You're going to radiate those patients, or you're going to give them chemotherapy. To what end? We talk about lobulars and we're always surprised by the number of nodes. However, are you really doing that patient a favor by giving them a chemo that the cancer probably won't respond to, or maybe even the radiation as well? So we act like it's a big deal and it's a big sneaky thing, but are we really helping those patients by knowing that information? That's my devil's advocate moment.
I don't know the answer to that, but I do still believe that involvement is still one of the most important prognosticators, including molecular, obviously.
More important than biology of the cancer?
No, obviously, that's why I'm saying molecular subtyping and analysis as well. But it's still a really important prognosticator of outcome. It worries me sometimes when there's a lot more than what's radiologically evident. A patient having a mastectomy may not have had post-mastectomy radiation therapy if the axillary extent of disease wasn't known. The management of the axilla is becoming more and more complex. I'm glad to hear that Carla was so happy when this was the topic, because I really wanted to vomit because I hate.
So I love this topic.
I do too. So I think part of the argument is, are we figuring out that it's important to know whether you have no nodes involved, low likelihood of having nodes involved, or having 2 to 3 lymph nodes involved? Knowing that somebody has 14 lymph nodes, you might argue that's kind of an extreme case, but is it more just the presence or absence of axillary disease that becomes important?
Presence or absence, of course, but where I was getting at before was the multidisciplinary aspect of it. There are still situations where it would affect multidisciplinary management. For example, with that post-mastectomy radiation scenario that I was discussing.
Oh, I think multidisciplinary is absolutely imperative. So for instance, when Z11 first came out, if you didn't have buy-in by your colleagues, you're hanging out there. And so it's really important to make sure that people are agreeing and that you have other resources for management as well.
I guess my main question to all of my brilliant co-hosts are, what study is there that removing nodes is therapeutic? Is it diagnostic or is it therapeutic? And if it's therapeutic, what study was that? I don't recall.
Now, there's not.
And I guess my question about
that's why I don't recall it.
Right. It's diagnostic, right? I mean, that's what it is. And I love talking about Z1071. So that was another big trial that when I was a fellow, we enrolled a patient on that. That was the trial that honestly was a negative trial up front, but it was looking at the false negative rate of sentinel lymph node biopsy for patients who had initially node positive disease and then had neoadjuvant chemotherapy. And I think the important part of that is that they weren't looking at oncologic outcomes. What was the overall survival or disease-free survival or local recurrence? Because all of these patients had an axillary dissection. It was a surgical trial looking at the accuracy of sentinel lymph node biopsy following neoadjuvant chemotherapy. And so that is one of the areas where we as surgeons, it's such an important piece of information that we hand back to the patient, but more importantly, the medical oncologist and the radiation oncologist about that patient's next steps. And if we don't give them the correct information, that can have significant implications.
So are we doing this to appease our colleagues in medical oncology and radiation oncology so they do certain treatment or don't do certain treatment? Is our goal to all be on the same page as to de-escalation of care?
I mean, I think your point of who are we treating here? Are we treating the tumor board or are we treating the patient? You could get to Carla's argument that, well, you can have a complete pathologic response in the breast that you didn't get in the axilla, and therefore there's a reflex therapy to that. But I think that goes to study design, because still probably medical oncology is holding on to nodal status more than maybe we should. I think the next frontier is going to be, can we see genomic changes or things along those lines? Because really the nodes have always been a surrogate of disease aggressiveness. And if we get other mechanisms of determining that, then leave the axilla alone, because it's not always one-to-one. The lobular that we talked about might not be any greater risk of metastasis by having 14 nodes than a triple negative that has 14 nodes. So I think we're heading towards genomics. I talked all the way around a circle and didn't really say a whole lot. But I think your point's well taken, Susan, in the fact that we may be trying to treat a tumor board much more than we really are thoughtfully treating that patient.
But Carla, to your point of 1071 being a negative trial, and it is. And I remember sitting in San Antonio as it was presented, and I thought, this is a negative trial. Like, yeah, it's interesting to see a negative trial. And that was adopted almost overnight.
Yeah.
And not because of the findings. We adopted it so quickly because we were ready to, because we believed that if those few nodes were negative, even though they were positive, you had neoadjuvant treatment, and they were now pathologically negative, we believed that was the answer, and that dissecting that axilla is not going to benefit the patient in any way, shape, or form. So even though it was a negative trial, it was a paradigm shift. It was adopted very quickly, and I think it was the right time, and I firmly believe it's the right thing to do for patients. But why are we not moving quicker at this time?
I'm wondering too, like, how would that accrual work for no management to the axilla? I mean, we have a lot where it's a sentinel lymph node biopsy or it's not doing an axillary dissection, but in people where it could be borderline in just doing nothing, no radiation, no, like not having that information, I think that's a huge shift and going to be really difficult to explain. I think.
Is it really no information? We know that they are clinically node negative. We know that they've had axillary ultrasounds, and that by the imaging criteria, they are node negative. So I don't think we're not doing anything. We've evaluated the axilla. We've just evaluated it in a different way, not a surgical fashion.
So I guess then my question is, say you do a mastectomy and you were clinically node negative and you do a sentinel lymph node and it's positive, how are we handling that information today? Mastectomy, they had recon.
Well, I would go to the Amoros trial, right?
Yeah, Amoros.
So, and I think it's important, right? We're talking about de-escalation and we're kind of jumping around between like axe dissection and not doing sentinel nodes. And I think we might argue that they're the same things, but I would argue that the de-escalation of an axillary dissection to information we gain from sentinel lymph node biopsy is somewhat different than sentinel lymph node biopsy versus nothing. And the other thing, and this has been a huge pet peeve of mine, is that we talk about this de-escalation and the radiation oncologists are radiating these axilla. And I think there can be some benefits to both, but I just think that's one of our struggles. We mentioned the sound trial. So there was the sound and the Ensema trial, which were both published in the last year, and both of them looking at a much bigger population and avoiding sentinel lymph node biopsy, again, in patients that were probably candidates for Z11 up front. So kind of these early stage clinical patients. And we are struggling figuring out what patients are eligible because of the implications for radiation, and not just whole breast radiation, but nodal radiation. And I would kind of throw that back out there to the group. Do any of you guys have protocols for who you're avoiding a sentinel lymph node on, or is it a case-by-case basis?
So we have buy-in from the team, the multidisciplinary team, which I firmly believe is critical, that 65 and older, luminal A, clinically node negative, and they have to have a real ultrasound of the axilla, not cursory along with their ultrasound because they have dense breasts. It has to be, I know this patient has cancer, I'm looking at the ultrasound of their axilla with those eyes. So it is a much more careful examination. And for those patients, we will omit the sentinel node.
And then what do they get for adjuvant radiation? Do all of those patients get whole breast with no nodal radiation?
Some will get partial breast. So they will do partial breast in those patients, even though the trials were whole breast radiation. We know with the whole breast radiation, the advantage is you're going to radiate a certain percentage of the axilla. And the hope is, even though we don't remove any nodes, if there's anything there, the whole breast radiation part that covers the axilla will cover it. So we will give patients partial breast radiation as long as they meet those criteria. I mean, think about women 70 and older. We're omitting radiation in them altogether. And we're omitting sentinel nodes. We're omitting radiation. We still have systemic treatment, which does an incredibly good job.
Yeah, I wanted to piggyback off what Susan's saying, because that's the point that my hospital and group keeps coming back to. In these luminal A's, if you're going to de-escalate the axilla, that's great. You can probably de-escalate the radiation as well, because the radiation is not proven to really help those luminal A cancers and control that disease, or DCIS for that matter. So their big emphasis for us is the compliance with that systemic treatment is an issue. And if the patient isn't going to be compliant with that, you do need to maybe think about radiation or something in those situations, versus if you're going to set them free, if they're not going to take their systemic therapy, if they're not going to do the radiation and they don't get a lymph node, what happens to them?
And like sometimes that's difficult. We can't predict who's going to be super successful doing their systemic treatment and who's not. But I really think, Susan and Carla, what we've discussed is this multidisciplinary approach is essential. We have to all be on the same team. And I think it's also helpful sometimes for patients to be able to hear these risks, and really defining local versus systemic recurrence is super important.
We talk a lot about the multidisciplinary aspect, but part of, I think, the discussion for our group is surgeons. You have a newly diagnosed breast cancer patient, right? She finds out today she has breast cancer. She's going to see you in a couple days, a week, whatever the time turnaround is, right? But she's seeing you, the surgeon. Now, obviously, some people are in multi-D clinics. I'd say those are more the exception than the rule. It is important to have those discussions about what the group wants to do with certain patients ahead of time, kind of like what Susan talked about. But patients don't always fit those categories. And the struggle that I have is trying to have those conversations with patients ahead of time, talking through their cancers, and then really trying to navigate, like, are you going to take your endocrine therapy? Okay, I feel comfortable. Are you kind of leaning against radiation? Well, then maybe I should do the sentinel node. And it just feels like it's adding more and more conversations. And I do bring up some of these patients. I think I have a patient coming up on my tumor board where I'm going to discuss whether she meets criteria for the sound trial and whether I can omit the sentinel node, but I can't do that on every single patient. And so I am, as a surgeon, making those decisions in the moment all the time. And I'm sure you guys are as well.
Yeah, exactly. We don't have a protocol at this point implementing the sound per the trial specifics, but we've talked about it a bunch as our multidisciplinary team. We're a heavy axillary de-escalation group. We just stopped doing ax dissections a long time ago and never really looked back, even in settings where it's still considered standard of care or clinically normal to do it. I'm really proud of our group in that sense. We've come together and really abandoned axillary dissections in most situations. With the omission of sentinel lymph node biopsy, at this time, it's our patients with multiple comorbidities, with the luminal A, with over 70, as Michael alluded to earlier. But we're getting closer and closer to probably implementing an actual protocol about it. I know a lot of programs do have that now.
We really work to de-escalate. Not everybody works to de-escalate. I mean, the radiation oncologist, you mentioned that before, Carla, I'm not sure how much they're really working to de-escalate. We sort of step back and go, well, okay, I got it from here. You don't need to have the surgery. And they never really ask themselves the question of, do I need to do this? We need to look at maybe pushing our colleagues a little bit more to buy into de-escalation that we're doing, the medical oncologists are doing, and maybe the radiation oncologist.
I don't know. We have a really successful relationship with those, but I agree that across the United States, you're going to have variability. And Carla, I finished in 2011, and I remember getting interviewed for a job because I knew how to do sentinel lymph node biopsy. They were all still doing axillary dissection. And so I think there are places where there are different therapeutic options being offered. And then there are certain communities where the whole team is on a de-escalation approach that's appropriate and is evidence-based on there. How do you all explain targeted axillary dissection to your patients?
Before we get there, can I just ask a question? So if we have these discussions always, and you go to any tumor board across the country, and a question of this nature will come up, how do patients know? How do we expect patients to know what the right treatment is? We all have families, we all have friends. How would we guide them if this is not what we did for a living, where to go and what treatment is right? How do they even begin to figure that out?
Whether they should have an axillary dissection or not, or a sentinel node or not, like if we're presenting that.
Right.
I always say, if we present something like, do you want pizza for dinner or do you want a sandwich for dinner? Well, I know what pizza tastes like and I know what sandwich. And it's like, well, we're kind of throwing out these nebulous things. Part of the cancer journey is the not knowing, and you can do as much research as you want. You can see the best doctors, you can see multiple doctors, but like, unfortunately, there will never be 100% certainty. And one of the things that comes up with my partners, and I'm sure a lot of you guys do this as well, is, sometimes we have these email tumor boards or texts where it's just like, hey, I've got this patient, what would you do? I think a lot of the younger surgeons have like the WhatsApp and kind of talk about it. And one of the things, because again, I like to talk about the axilla a lot, but I will tell people, I'm like, there are certain situations where there is no wrong answer. You can do an axillary dissection and be justified in doing it, and you can stop at the sentinel lymph node. And I think we do our best job to kind of overview the information we gain or the information we don't gain. We all know that there's patients, and I use the term throw the kitchen sink. They want to do everything possible, and they're confident in that. And that's a good discussion. There's other patients that play pickleball, and getting back to pickleball is kind of the most important thing to them. And I think that we know those are patients where omitting maybe an axe dissection or sentinel node is going to fit with their preferences.
Believe it or not, we're just about out of time. I hope you're enjoying this podcast as much as I am. I think about this content long past the episode. And so I wanted to go around and have each of you share one thing that you'll take away from this episode. Sitcha, let's start with you.
I think it's obvious that we all agree that de-escalation is important, not just in the surgical discipline, but across the board, and that there's a plethora of clinical trials and other studies to support that approach. I will be very happy for the day that we no longer need the axillary staging and have a genomic blood test that'll tell us what a patient's true risk is to help guide management and just take that out of our clinical tool and armamentarium.
Ellie, what about you?
The individual patient aspect, like everybody's talking about the pickleball player versus the worrywart, all of the different flavors of patients that we come across, and just remembering so much that no matter what the data says, you always have to match what aligns with the patient in addition to what the research says. So sometimes you do things that go with the guidelines, sometimes you don't based on the patients, but it's always a good reminder to always keep the patient at the center of everything.
Michael, you're not allowed to talk about 9347. Give us something different.
Well, it's 93-43, I think.
93-43-23.
Exactly. Being old.
Locker combination.
Being old, though, allows me some perspective of where we started and where we finished. And that's very interesting to me. I want to pat breast surgeons on their back. The fact that we're stressing over this tells us that we are really interested in keeping up and providing the best care for our patients. The easy thing to do is to freeze what we know, where we stop training, and the patient gets 20-year-old medicine. So the fact that we stress this and worry about it and how do we provide the best care for our patients really is kind of heartening to me, that I think we're doing it right, that there isn't always a right answer, but we know that this whole field is evolving, and it really is evolving for the patient's benefit.
All right, Susan, you're up.
So I completely agree with that. And I think the key is to never stop questioning and never stop learning. And it is something that, as Michael just said, we're really good in breast cancer treatment, in breast surgery. We constantly question, but we do have to believe the results. And there are times where we get an answer and then we just redo that same study and over and over again to prove the answer that we had 35 years ago. So sometimes you just do have to believe that answer, but never, ever, ever stop questioning and learning.
Carla. Whenever I talk about clinical trials, I always say thank you to all the patients who enrolled in these clinical trials and have given us such great information that we can use to treat our patients today and in the future. So thank you. And I would say the other thing that I'm going to do based on this podcast is really kind of follow up with my group and come up with a more strict protocol for our sound patients. I've been kind of waiting, to be honest, for ASBRS because I think there'll be a lot of planned and somewhat organic discussion about that given these recent publications. And I think following that, I'm going to sit down with my group and with our radiation oncologist and really come up with a protocol on who we can safely avoid sentinel nodes on.
That is a perfect segue. So to our breast surgeons, I would say look to the ASBRS for guidelines, and you can submit cases on the forum, and hoping to see you at the meeting. And to our listeners throughout the breast community, we're excited that you've joined us on this journey. Comment on Facebook. Please make a name for 23 Michael's Cow. And we're going to see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
Sitcha,
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next